Hi everyone, I'm Dr. Giovanni Cacciamani, Associate Professor of Urology and Radiology Research and Director and Head of the Artificial Intelligence Center at the University of Southern California. I want to congratulate the Committee for the Focal Therapy meeting and the Society of Urologic Robotic Surgeons for the excellent job done this year of merging these two entities in this composite meeting. And I just want, of course, to thank the chairs of this session for inviting me to talk about how we can use artificial intelligence to improve the focal therapy planning and the patient selection using the multiparametric MRI. I have no conflict of interest. As urologists treating patients with focal therapy, we have always to consider how we are going to follow up those patients. Recently, Amir Lebachi and the focal therapy meeting team, they put together this international multidisciplinary consensus, coming up with a recommendation for following up patients after focal therapy. And the imaging that was recognized of being the most effective was the multiparametric MRI. That should be done at the first time at 6 months, and then once basically every year. Specifically, the author of this consensus recognized the multiparametric MRI as the preferred imaging modality in 97% of the time, as it is the most established imaging modality. But also, they come up with a list of MRI findings that should be suggested for failure, or, in other words, also for persistence of the disease inside the prostate. However, when we are looking at the sensitivity of the multiparametric MRI in detection of prostate cancer after focal therapy, we can see that different studies being reported and different type of focal therapy can be used. But again, when you are looking at the sensitivity in detecting the recurrence, or in other words, also the persistence of the tumor, is extremely variegated, extremely heterogeneous. For this reason, very recently, the Barry Stork-Bay team has put together a new system that should ensure to provide, like in a PIRATE score, a prostate imaging after focal ablation scoring system that was done in a methodological perspective, in a retrospective evaluation with 33 patients. And the outcome of interest in this particular study were the inter-rater agreement of the prostate imaging after focal ablation scoring system, the sensitivity and the specificity of this tool in detecting the sign of failures, positive predictive value and negative predictive value, and of course the overall accuracy. Specifically, as you can see, the system is looking at the 4 different phases of the multiparametric MRI, and here you can see 2 different examples of pre-treatment and post-treatment for the multiparametric MRI and the evaluation of the prostate before and after the treatment. When we look at the inter-rater agreement in the MRI for this for the PIFAB, we can see that the distribution for one reader was 15 scans, 1 scans for 3% score as 2, and etc. But as you can see, the most important thing that we have to consider is the moderate level of agreement that was between both the reader with a K of 0.56. This, of course, is making the point that this kind of system which has a very high sensitivity and a negative predictive value, but on the other side, a low specificity and a low positive predictive value. And again, the main reason is because we have humans that are looking at the images that are very difficult to read because of all the changes that happen in the prostate, compared with the clear imaging that can be seen at the time of the scheduling of the patient for the focal therapy. So technically, for this particular reason, AI could potentially be an ally for improving the way that we can follow up patients through an evaluation, or in other words, a prediction of the pathology from the radiology in what we call the virtual biopsy. There are 3 main things that we have to consider specifically when it comes to the use of artificial intelligence for prostate. The automated MRI reading, how AI could work in focal therapy, and why right now is not yet integrated. Let's start with the basics. Automated MRI reading. To understand how artificial intelligence works in the prediction of the pathology from the radiology, we have to consider that each multiparametric MRI is done by different pixels as you can see here in the image. And each pixel has what we call the pixel to radiological characteristics. Each one of these characteristics will be pretty unique for normal tissue or for cancerogenic tissue. Now, each particular pixel in the imaging has its corresponding evaluation and interpretation into the pathological specimen. And each of these pixels is what we call, is putting together what we call the pixel to pathological characteristics. Now, artificial intelligence is a way to merging the pathological characteristic and the radiological characteristics and finding what we call the pixel to radiopathological characteristics. Now, looking at again to the same multiparametric MRI, we know that some pixels are into a lesion and some other pixels are into a normal tissue. Again, if we are looking at those pixels or to pixel to radiopathological characteristics, the ones that are into the area or region of interest will be recognized to have pixel to radiopathological characteristics that are specific for clinical significant cancer. In other times, other pixels that are in areas that are not region of interest will have what we call the pixel to radiopathological characteristics that are specific for non-clinical significant cancer areas. At the time that we create what we call the ground truth, or we train the model in understanding those pixel to radiological characteristics. The first thing is the pathological foundation. The system will be fed with already cases that has been read by pathologists and radiologists. And all those cases then will be put all together to identify common characteristics that are always in common for areas that are recognizable for being clinical significant cancers and areas that are not recognizable to be not clinical significant cancer. In other words, we are creating an identikit, like a real list of pixel to radiopathological characteristics that are always in common and that can recognize the tumor versus non-tumor. Now, once the ground truth is done, at the time that we feed the system with a new case, the system extracts the pixel to pathological characteristics and compare them with the ground truth that we discussed before. And they will recognize the cases that are clinical significant cancers versus those who are not clinical significant cancers. The use of artificial intelligence and the evaluation of the performance in the prediction of the pathological characteristics from the radiological characteristics is an extremely florid field in the artificial intelligence arena. As you can see here, there are a lot of potential application of the use of artificial intelligence for prostate cancer, but the three main tasks that can be done by automatically or semi-automatically by artificial intelligence is the prostate gland segmentation, the prostate lesion identification, and prostate lesion characterization. So when we're talking about the prostate gland segmentation, as you can see here, it means that the system is able to automatically or semi-automatically correctly identify the borders of the prostate. And looking at the data from a recent system, the prostate lesion identification is extremely important too. We are looking at the prostate, which was previously segmented, and the AI system in an automatic or semi-automatic manner can identify the lesion and therefore making the boundaries of the lesion itself. Our systematic review that is recently started has identified that this system in the prostate lesion detection and prostate lesion segmentation has an accuracy that is between 0.90 and 0.97 for the detection and a little bit lower for the segmentation. Reason is basically related to the variability of the pirates lesions that were used for training the systems. And then, of course, the prostate lesion characterization. So in other words, if we have a lesion and the lesion is in the imaging, how we can make the imaging being read automatically by the artificial intelligence and not only identify the lesions, but also telling us if in front of us we have a clinical significant cancer or a non-clinical significant cancer. And looking at the data are showing that this type of characterization has an accuracy that is between 0.8 to 0.96, dependently on the data set that was used. This actually is just to give you an overview on how the general the urologist, the urology community is working tirelessly in finding solutions that are implementing artificial intelligence into an automated or semi-automated reading of the multiparametric MRI, and how those systems could potentially impact in the way that we can predict the pathology from the radiology. Besides the enthusiasm around the use of artificial intelligence and the very promising results about this technology, what we have to consider is that we don't want to compare AI versus physicians, but instead having AI assisting us in making a better prediction. And this is also shown from a recent systematic review that we performed, the meta-analysis, where you can see here on the left side of the slide, radiologist alone with a cumulative performance in detecting clinically significant cancer of a cumulative sensitivity of 79.5 and a cumulative specificity of 73.1. But then when the same radiologist is assisted by artificial intelligence, the cumulative sensitivity jump to 89% and the cumulative specificity jump to 78%, making the point that this kind of technology cannot do the job of a radiologist, but on the other side could potentially assist the radiologist, and why not the urologist, in better reading the images, and particularly the multiparametric MRI, in the detection of the clinically significant cancer. As you see, Dr. Masatomo Kaneko will discuss that later on. I don't want to discuss too much on this, but this is basically a system that is implementing all those tasks like segmentation, detection, and classification all together in what we call the PIRADS for automating the entire experience from the segmentation to the ROI classification in an automatic way. And our system shows that in a green learning heat map, that when we are feeding the system with different phases, the system will create it automatically in a fully automated way, a green heat map showing you where is the lesion and the prediction of this lesion of being clinically significant cancer. How artificial intelligence will work in focal therapy. So right now there are very limited evidences on how we can use artificial intelligence in focal therapy. And on one side, this is extremely good from a research perspective. And that's why, as a focal therapy society, we have to come all together and sharing the data for trying to train systems in order for making better prediction and using the artificial intelligence and creating ground truth systems, as I was showing you before, in making a better prediction in patients during their follow-up. The AI can be used for treatment efficacy and also for area to treat prediction, as you can see here. For treatment efficacy, we have to consider exactly what we have said before. Again, we know that for each patient, we have multiparametric MRI done before the treatment and also multiparametric MRI done after the treatment, accordingly to the consensus, which says that the multiparametric MRI should be done at 6 months after the focal therapy treatment. Now, the very first thing that you have to consider is that the AI should look at the before the treatment MRIs, and as I was mentioning before, looking at different pixels and identifying basically areas that are areas of clinically significant cancers versus areas that are not cancer at all. And is what is an evaluation and a prediction of the pixel to radiopathological characteristics specifically for clinically significant prostate cancer, as you can see in purple, and the pixel to radiopathological characteristics for non-clinically significant cancer, as you can see in green, and creating what we call a mask. Now, this mask should be stored, and at the time that we are looking at the after treatment, as you can see here in yellow, we're going to have the area treated. In green, we will have basically the normal tissue. But technically, what we have to consider is also borders where the lesion was before the treatment. Now, in a system like this, the artificial intelligence should consider and extract the pixel to radiopathological characteristics of the area treated, the pixel to radiological characteristic of the area that was not treated, and considering where was the lesion, comparing the before treatment and after treatment masks in order to find out if, in this case, the pixel to radiological characteristic clinically significant cancer are not seenable anymore, and in this way it means that the system is effectively predicting the fact that the treatment was successful. Or, in other words, in the case the system can identify areas of pixel to radiopathological characteristics that can identify clinically significant cancer compared with the same clinical significant pixel clinical significant cancer characteristics that were found before, and that will tell us that actually there is failure or persistence of lesions inside the area that was treated. Another option is the use of area to treat prediction. Very recently, the UCLA just published this paper where basically they look at the validation of focal therapy treatment margin produced by artificial intelligence model to predict basically how they can use a mapping of the intraprostatic tumor stent with artificial intelligence and therefore planning better the system. As you can see here, they look at retrospectively 250 patients who had radical prostatectomy for intermediate risk cancer, and then they use an AI deep learning model that was incorporated with the multimodal imaging. I will show you that in a few seconds, and the biopsy data to produce a three-dimensional cancer estimation map and margins that could potentially be used for predicting the area to treat using artificial intelligence. And as the outcome of interest here, you can see the comparison of artificial intelligence with the conventional margin, the sensitivity, the negative margin rates, and also the predicted versus several negative margins probability that was evaluated using, of course, a linear regression in this case. As you can see, the input data in this case were the multiparametric MRI, the PSA, together with the biopsy and the pathology of the biopsy. The model architecture, as you can see here, was able to merge in the imaging data and the biopsy pathological data together with the patient characteristics. And those actually were able to create an heat map, as you can see on the right side of the slide, where the system was able to make a cancer estimation prediction map and also a treatment margins that should be considered at the time of the planning of the focal therapy. These are some examples of the prediction of the estimation of the area that should be considered in order to avoid any positive margin at the time that you have the radical prostatectomy. And again, as you can see here, the mean sensitivity for cancer-bearing voxel was higher for AI margins, 97%, compared with the conventional region of interest, that was 37%. And again, as you can see here, the negative prediction margin rate was from 74% to 80%. Again, those data are extremely good, but are promising, but require being validated externally. So the other option, the other question we can have is, okay, we know how AI can be used for automating the MRI reading. We know what could potentially be the options that we have in focal therapy. So now, why those options are not yet integrated? The main reason of the not use of this kind of technology right now is the lack of explainability of the existing models. The majority of those models are very, very shoddy. It's very difficult to understand how they come up with the solution, and more transparent models are needed. On the other side, different AI models and different databases. And the majority of the databases out there are not reliable enough because are old databases and are using different MRI imaging that is not even the imaging that it was most used right now. The majority of those datasets, unfortunately, lack of prospective maintained datasets, and specifically for focal therapy, there is no stratification for the different energies that are going to be used. So data are needed. And for this reason, as a focal therapy society, we should come up with a composite database that is including all the possible energies, different centers, different settings, to try to train AI models in predicting the recurrence or persistence of the disease, starting from the multiparametric MRI that, according to the nomenclature and to the Delphi consensus done last year, should be done at 6 and 12 months. Take-home messages for this talk. AI in prostate cancer diagnosis, we know there is an emerging tool for automated prostate cancer segmentation, and enhances also the detection and characterization of clinically significant cancer. In terms of AI and focal therapy for prostate cancer, we see that could potentially be useful for evaluation of the recurrence detection, and standardization of the area to treat can be done effectively. But of course, these data, even though are promising, require a standardized prospective validation. There are issues with model in terms of explainability, data reliability, and test heterogeneity, and these factors limit the validation and scalability of these findings into the clinical practice. And the future direction, as again, we need for more research and interdisciplinary collaboration between different centers in putting together a huge imaging database that can be used for training AI system.